Today evening, we are here to discuss a very controversial thing, a short and crisp discussion with the legend, Dr. Sunita. I would like to briefly introduce Dr. Sunita Tandulwadkar. Ma'am is head of the department and chief at IVF and Endoscopy Center, Ruby Hall Clinic, Pune. And she is a senior IVF consultant at DY Patil and IVF and Endoscopy Center, Pune. Dr. Sunita is the founder and medical director at Solo Clinic IVF and Solo Stem Cells, a stem cell research and application center, Pune. Dr. Sunita is a dedicated academician. We all have been learning a lot from ma'am, and today we decided to discuss the crisp points on pre IVF hysteroscopy. As we know, in recent years, hysteroscopy is being popularized by various live workshops, and a lot of times clinicians are suggesting hysteroscopy to all infertility patients, be they are for IVF or for a regular workup. Dr. Sunita, I would like to take your opinion. How do you suggest hysteroscopy to your infertile patients in your practice?
Frankly speaking, first of all, Arti, thank you so much. Thank you for this novel idea, and thank you for coming out with this topic, which has a lot of dilemmas. But I will say that hysteroscopy is underrated by the gynecologist. You can just put in a camera inside the cavity and you view the entire cavity. Is so important because whatever the great embryo is, whatever the lining is, the implantation, this is, if you can check the uterine cavity, it's nothing like that. And I will say, forget only infertility, any patient with perimenopausal bleeding and all, it should be always see and treat. So how PSPV, per speculum per vaginal, we used to do in our postgraduate or residency, and transvaginal sonography has become our extension of examination. The moment we do the PV, or many a times we don't even do the PV, we directly put the probe inside to check. Then office hysteroscopy should become an extension of a transvaginal sonography. So hysteroscopy plays a very important role. Now, the dilemma, probably you may ask me in further, whether we should be doing it for all in IVF patients.
Yeah, ma'am, one more thing I wanted to know, how often do you proceed with vaginoscopy and hysteroscopy in your OPD patients? Like a lot of times when we put in the probe and we see a polyp on TVS, how often do you decide at that time, oh, let me do a quick office hysteroscopy and get rid of this polyp to give her a good cycle this in the same month?
Yeah, okay. Arti, it depends upon what stage of, if patient has come for the first time in a OPD, and on transvaginal sonography, if I see the polyp, I don't immediately take her for a office hysteroscopy and do the polypectomy. First of all, patient needs a lot of counseling also that we have to show. We have to see that is only the polyp cause of a infertility or there are many other factors. So I just show her the polyp and I tell her, probably I might have to tackle with your polyp, but I would like to do her baseline, even hemogram, her HIV, hepatitis, semen analysis, her sugars, her thyroids, basic test. Unless I do, I don't. But do I do the office hysteroscopy routinely in the OPD? Yes. Fortunately, in Ruby Hall, I have a complex where the OPD and immediately there is a endo-OT. So office hysteroscopy, as per by the international norm, it is next to your cabin, where in an office you have all the setup and you do it. I don't do that. I don't do in my sonography room the office hysteroscopy. For me, the office hysteroscopy is always taken in the operation theater. But the other norms, like patient is awake, we don't anesthetize, we do the painting draping along with me on a monitor which is there on the wall. She can also watch what I'm doing. We do the vaginoscopy. More or less, these are the nulliparous, so distension happens very easily. Otherwise, you ask one of the assistant to close the introitus, so you get a good intravaginal pressure and you can watch the cervix very well. And then the moment you go near with your good pressure inside, of course, this all needs a counseling. You have to tell the patient that when I'm going to enter in your cavity, with the uterine distension, you may get the pain. So here you need a very good coordination between you and your ward boy.
Yeah.
Here, instead of the hysteromat, I use the pressure pump, so that I can control the fluid going in. So he's putting the pressure pump. I'm doing a vaginoscopy. The moment I go near to the external os, usually the cervical mucus which is tickling, which will be showing you where the direction of a cervical mucus. And when you open, it's like a fish mouth. It gets opened up. Then the cervical folds allows you, because all folds goes to the internal os, they allow you to go to the internal os. And the moment I see the internal os, my ward boy who is with me for last 27 years, he automatically stops putting a pressure, because then I go inside and I can visualize. If you go it in a beautiful, non-traumatic way, it is absolutely a clear vision inside. Or sometimes you might have to make an outflow on, then start your inflow in again with a little less pressure, because she's awake, she's getting uterine little cramp. Sometimes the patient has a very good pain threshold and they are watching beautifully even without having any wincing on their faces. Sometimes they start wincing. So there you need to have a quick look on the cavity and everything, and then you come out. If you don't mind, Arti, in 2 minutes, shall I share one beautiful video when I'm talking to you? This is where I feel very important. If you see on the left side, can you see? It is the internal os. And with the hydropressure, these flimsy adhesion fibers I'm breaking. This is a very early tuberculosis. If I would have dilated and done a routine hysteroscopy, I would have missed this finding very easily. And with the hydropressure, you can see I'm just opening in and I'm going in, and you can see the flimsy fibers there. Can you see that? Those flimsy fibers, these patient, I have sent a TB PCR RNA study and it had come positive. So sometimes the office hysteroscopy plays a very, very important role over your dilatation and examination with 2.9 or a 4 telescope, where anesthesia may be needed, where with your 2 you don't need anesthesia, and so on. But coming to your question, I'm sorry. So instead of doing in an office, in the OPD, I do it in the operation theater, because I don't have a setup of all the camera and everything, even in the OPD. This is an expensive setup. So I take the patient in, but no anesthesia. We walk in and they walk out.
Thank you, ma'am. Thank you for sharing the very important tip. Even I agree with you. In countries like US, where if you admit a patient, the cost on the patient goes many times. In those settings, it's justified to do office hysteroscopy. But in our country, if we have access to OTs at our own choice and ease, why do we take the stress of doing an office procedure if we can take our patient into a safer, more sterile environment with proper setup, and we can get a better outcome of a procedure? And in case of pain due to vasovagal, we have access to all the emergency drugs also, and we can save her from the adverse effects of the procedure. Thank you for sharing this. And your description was like, I could see going inside the vagina, passing through the cervical canal, and then you get the view. Beautifully explained. Ma'am, I would like you to share some recent data which can give us the exact outlook. Do we do hysteroscopy? Like there are a lot of studies nowadays, Insight study, Trophy study, which tell us clearly whether we do hysteroscopy for the first IVF case, is it recommended or not? or in cases of recurrent implantation failure. So please throw some light on the latest studies and multicentric outcomes of these studies.
Yeah, very nice question. And Arti, I'm so happy. This is such an important topic you opened up. Now, let me tell you first the evidence, and then we will say what with the experience what we do in our setup. Now, if you see the studies, actually in 2014, Josna Pundir's meta-analysis, which has, brought into the picture where they have done a meta-analysis, I think, with the some 3,000 plus women, and what they have said, which was, very highly spoken in 2014-15, everyone used to quote, because they have said there, it was very clearly that their outcome was like, I think, pregnancy rate and the live birth rate in all the asymptomatic. It means there were no complaints to the patient. And they have included in that meta-analysis 6 studies, and they have found that hysteroscopy prior to even first IVF was found to be increasing the pregnancy rate and the live birth rate. That was a Josna Pundir's meta-analysis. It was very well discussed, I think, for a long. But then what you said was an insight study or the trophy study. Now, Josna Pundir said that even before you do the first IVF cycle, please do the hysteroscopy. It will improve your pregnancy rate. While if you see the trophy studies and all, which probably 2016 and all in Lancet, it got released, they said very clearly that even in the recurrent implantation failure, even in a repeat IVF failure cases, there is no role of hysteroscopy to improve your implantation or a pregnancy rate. Okay, so, and they're not only, these are the very well spoken meta-analysis or the studies, but there are individual article, I don't remember who was that, 2022 only, I recently read, they said very beautiful word about it, that it was their, what you call it as a, their own center study it was, and they said that if on a sonography you did not find anything, then doing a hysteroscopy, and even if you find small tiny polyp, it was not significant to give an implantation failure. So if it is not diagnosed on your very good 3D sonography, role of hysteroscopy goes 0. Absolutely. Even 2022 article where they studied the best way to check the uterine cavity, 3D sonography versus, I think it is in fertile sterile only, 3D sonography versus hysteroscopy versus saline infusion hysterography. And they said saline infusion in hysterography, they found much superior, much easier, much economical to do in the setup. So now, when the evidence doesn't allow, Arti, do I follow that? I'm sorry to say no, I do hysteroscopy, because this is the platform to say what we do openly to our people. Now, what happens, in our places, as you very rightly said, the cost of the hysteroscopy is in your hand.
Yeah.
It's not, the patient here is not paid by the Mediclaim or by the government. For the Western country, it is a different story altogether. They have to follow their norms. The hysteroscopy, if it is not sponsored, it becomes damn expensive for them. But for me, if the patient, I can do in a very economical cost to the patient, I definitely feel the little added advantage. So what do I do to take this added advantage? We all have 1 decade ago, or maybe 5-6 years ago, we're talking a lot about endometrial scratching. In a previous cycle, to optimize your implantation, because it does cause aseptic inflammatory reaction. And it helps us to improve the implantation. So 1, I do this office hysteroscopy 1 cycle prior to the transfer. My 99% of the cases are the frozen embryo transfer, so I do that. Second thing, I feel sometimes when the internal os is going to be very tightly closed, maybe 1 in 100 or 1 in 500, your cervical canal is going with the difficulty, very acutely anteverted or acutely retroverted uterus. You know, we write down on those points in our embryo transfer diary with the patient's name. This may help you in 0.1% to optimize your embryo transfer. So it's like a mock embryo transfer or a trial embryo transfer, you can say. But for me, I think hysteroscopy adds on. Chronic endometritis is the only thing which I feel, especially in unexplained infertility or recurrent IVF failure, where everything is normal and you failed with you see chronic polyposis. Now, these polyposis, we may not be able to detect on a sonography. And that may be the reason. I think when you join the global hysteroscopy group, you are also the part of this community of a global hysteroscopy, and I invite everyone to join that. This has become like more than 20,000 gynecologists across the country coming together. When you see those videos of those micropolyposis and all with the chronic inflammation, which may be the reason of implantation failure, which may be the reason of unexplained. So there is definitely added advantage. So the evidence, it doesn't allow. In my practice, I do it. Unless patient says, recent hysteroscopy, they show me the video or done by the very good hysteroscopic surgeon, which I can believe blindly that they are the endo-ART people, because when it is the endo-ART people, they will check the hysteroscopy in a little different way. Only endoscopic surgeon may see it only as a view, like there is no septum, there is no polyp, there is no Asherman, there is no submucous myoma. The ART person will go and check more on the endometrium. They will go and check more on the endometrial texture, the polyps or these micropolyposis or any flimsy adhesions anywhere. They are checked little more carefully, and then I may avoid in those cases, Arti. Now your opinion.
Yeah, that's beautifully explained. Although the more you check, the evidence says it does not help. But in clinical practice and in experience, I absolutely agree with you. Chronic endometritis, patients will have implantation failure. And one good cycle of doxycycline for 2 weeks, you treat the problem and you get the result. And again, there may be multiple small adhesions which can be tackled and we can give better result. So,
absolutely, I agree with you, Arti.
Similarly, ma'am, people like this is not related to IVF, but I got a call from a very senior doctor that she has thickened endometrium, postmenopausal bleeding. Do a pipple biopsy. Do you do pipple biopsy? I said yes. She said do it. But when the patient came, I did her TVS. This was a clear-cut polyp. So I told her that rather than doing pipple biopsy, let me do a hysteroscopy and I could remove the polyp. And then I sent the pics to the senior consultant and she was very happy. She said, oh, I'm happy you did the way you wanted to do it. And she's treated now. She won't need another treatment.
If that polyp comes benign, the thing is done.
Absolutely.
Many times they label it as a thickened endometrium, but it is polyp.
And the time it's a polyp.
If expert 3D person will diagnose it as a polyp.
Yeah.
Otherwise, you do the saline hysterography, which is very simple, and you can see that the polyp hanging, and you can avoid so many hysterectomies for a postmenopausal bleeding.
Somehow I just love SHT. It's such a simple procedure. You put in saline and you can see the cavity so clearly. This is another armamentarium which is so easily available in our OPD, and we should be doing it more often.
I think, you know what, Arti, the next generation of the gynecologists who are coming, who are getting trained under us as a fellows, automatically the way they will do the practice will be totally different. Sonography and endoscopy will play a very important role in the young gynecologist's life.
Even right now, I see with lots of discussions, lots of trainings, people are picking up hysteroscopy, sonography as a routine, and I believe our OPD workup is not complete without this armamentarium. Yeah. Yes. But ma'am, that time is getting over. I'm so happy that you agreed for this crisp discussion, because knowledge is for sharing, and until unless we share it, we cannot improve our quality of treatment and the quality of services which we offer to all our patients. And I would like to do this kind of sessions with you in near future also, crisp 15 minutes points on
Yes,
some
Arti.
debatable topic, because you totally changed the course. Like you
Yes.
said, I do it. All the studies are against it. They
So
show
we will
that.
use this. This is a beautiful platform. Let's have a
Yeah,
core of 4 or 5 people who are interested. And Arti, we can do every 2 weekly. We take one subject, 20 minutes click discussion. What does the evidence says and what we do? We should be honest to tell what we do in our practice. Very important. You know what happens? We are here so much forced by the circumstances to give a IVF success in a very first cycle. And that's
absolutely.
why we try to find out any reason which can give us a failure, maybe
Yeah,
treat and then do the transfers.
very true. And although the trophy study says that there is no change
No,
in clinical pregnancy rate, in miscarriage rate, in take home baby rate, but practically we all know this small procedure helps, and the cost of this procedure may be 1/20th of the total cost of IVF. So even I
absolutely.
feel that I would be more comfortable checking the cavity first in a doubtful case. But of course, if a 2D, 3D ultrasound is absolutely normal and I trust my findings, then, and there is no other sign of infection, chronic PID, then we may leave it. Otherwise, it's better to go for hysteroscopy in doubtful cases. Ma'am, a final word from you before we close the session.
In 2011, when I was an infertility committee chairperson with Dr. PC Mahapatra as a president, Foxy, we did a program, See One, Do One, and Teach One. I feel hysteroscopy, forget only infertility, every gynecologist should know how to do the hysteroscopy, which is so simple to enter in and come out. And we used to call one of the delegate in the operation theater. You have seen one and now you do one. And they used to do it. And I feel it should become a part of our day-to-day practice. Hysteroscopy has to be. Without sonography, patient comes with menorrhagia. Without sonography, we can't say whether it is adenomyosis, fibroid, or it is a hormonal dysfunction. So same way, hysteroscopy should be. The cavity has to be treated. Sometimes, let us 1 minute more. I remember in my residency, if we are suspecting the malignancy, we used to take 4 wall, anterior wall, posterior wall, right lateral, left lateral, canal.
Example.
And you know what? We
Example.
as a houseman, were bothered the lecturer or whoever is giving anterior wall. Okay, we labeled anterior wall. We labeled posterior wall. Now,
Now no one even thinks about it because you can see it in toto.
and
Yeah, I
what
have
does the
forgotten it,
difference it
ma'am.
makes? What does the difference it makes? Whether it was
Yeah,
an anterior wall which has come positive or a posterior wall which has come positive, the treatment is going to be the same. I don't know the fractional curettage and all we used to do it. Of course, I do understand uterine cavity and cervical canal or the internal os, but anterior wall and posterior wall, what does difference it makes?
yeah.
So
Now we can see and take a sample, and a lot of times you miss a good specimen when you're doing a blind curettage. I
absolutely.
absolutely agree with you.
So see
I had
and
forgotten it, ma'am. Actually, I had forgotten fractional curettage. Yeah. Thank you. Thank you, ma'am.
thank
And
you,
it's
dear.
always a pleasure to meet you, to talk to you, and to
Same
always learn
here.
something good from you. A very good evening to all our audience, and we'll see you soon with another controversy, and we'll get a strong take-home message from ma'am every time. And do share your topics of choice which you want us to discuss. Thank you so much, and a very good evening.
Thank you.
Okay, ma'am.
Thank you, Arti. Love you. Bye.